and welcome to today's DigiNerve session. I would like to welcome all of you for this session. It's very, very heartening to see such a large number of students and ophthalmologists tuned in for today's program. And the whole concept of DigiNerve teaching has revolutionized training of postgraduates in our country in the sphere of ophthalmology. Personally, I have seen a vast improvement in the learning abilities of the residents at Aravind. And in fact, I've been constantly saying this, the changes which has happened in the last 1 year at Aravind with regard to the learning capabilities of the students has been phenomenally impressive. I've not seen such kinds of changes in the last 20 or 25 years. And I do hope that all of you would use this platform to the best of your ability, and all of you can personalize it for your own learning skills. So without much ado, we would like to go ahead with today's program. We have a very, very eminent speaker, Dr. Mahesh Kumar. Many of you would have studied his textbook in neuro-ophthalmology. He has already written a textbook in neuro-ophthalmology, and he's a very, very good teacher. He has an experience of more than 25 years in teaching residents. And today, he would be talking to us on various case scenarios. The way we have structured this program is Mahesh will actually be presenting cases, and in between, he will stop and ask some questions to you. This is not a questioning session, but a session which is supposed to stimulate your way of thinking. And please feel free to type in your questions in the chat. And I will moderate the session. And as we go by, both of us will gain experience. I from moderating the session, and you by attending the session. And hopefully we will have a productive course. So with this few words, now I would request Dr. Mahesh to talk to us on various case scenarios in ophthalmology. Mahesh.
Thank you, sir. First and foremost, I would like to thank Dr. Venkatesh Prajna, our Academic Director of Aravind Eye Care System, Madurai, Tamil Nadu, for having given me this opportunity and having invited me to speak in this platform of DigiNerve chat show on case scenarios in neuro-ophthalmology. So the learning objectives of this presentation will be to learn the methodical approach in the workup of a neuro-ophthalmic case, especially from the clinical standpoint. The next one will be to generate a differential diagnosis in a neuro-ophthalmic case with the given symptoms and signs. The third will be to identify important neuro-imaging characteristics, which is an essential part of neuro-ophthalmology pertaining to a neuro-ophthalmic case. And last but not the least, to identify the emergency conditions in neuro-ophthalmology, which may be not only important to the vision of the patient, but perhaps to the life of the patient. So I'll be describing this with certain case scenarios. My case one will be a 45-year-old female who presented with painful ophthalmoplegia and drooping of the lids on the left side of 1 week duration. She was not a known diabetic or a hypertensive. On clinical examination, the visual acuity of the right eye was 6/6, the left eye was 6/9, and the pupils in the left eye were mid-dilated and sluggish to light. Next, we'll see the clinical photographs of this patient. So, photo 1 shows a drooping of the lids, and the next photo shows some extraocular motions. You can see the limitation of the extraocular motility in all the 4 cases. And at this point, may I ask, what are the clinical points or the clinical findings seen in this patient? I request you all to type in the chat box, and we will be given 1 minute to collect the answers and then discuss them.
Yeah, Mahesh, actually, Dr. Vandana has typed it as ptosis. Of course, this is ptosis, but Vandana, can you actually try and give a differential diagnosis? Another doctor, Dr. Henna, has said about multiple cranial nerve palsy. Yes, agreed, multiple cranial nerve palsy, but can you try and give a differential diagnosis? That will be much better. Mahesh, another doctor, Deepika, has said it as orbital cellulitis. What do you have to say for that differential diagnosis?
Yes, sir. So, almost all the answers so far are right. There is a ptosis, there is an extraocular motility defects, almost restriction of all the ocular movements. And the third answer is closer to the right answer, shows an orbital cellulitis. So orbital cellulitis is an important differential diagnosis in this condition, considering that there is a lid edema, considering that there is a chemosis, and considering that there is some amount of water in discharge. So cellulitis is a reasonable, good differential diagnosis.
Mahesh, what is one other doctor has committed? It may be an optic nerve glioma. Do you agree or disagree?
I disagree, sir.
Any reason for your, can we give a reason as to why you disagree that it is not an optic nerve glioma?
So optic nerve glioma presents as a slow growing proptosis. It is usually it's a slow proptosis and it is a silent proptosis. We do not see large amount of chemosis and congestion as seen in this case, which is usually suggestive of an infective condition, whereas optic nerve glioma presents mainly with vision loss and a slow growing proptosis, and not in this fashion.
Okay, that's the advantage of this kind of teaching session. You can boldly put your comments in the comments box, and whether it is right or wrong, it's still a benefit for all the learners. One of the a person, Dr. Kavya, has said it can be a CCF, cavernous sinus thrombosis, or a superior orbital fissure syndrome. What do you think of that, Mahesh? Differential diagnosis?
Yes, sir. So these two are also very close to the actual diagnosis. Cavernous sinus thrombosis is a very good differential diagnosis, considering that we are possibly looking at an infective condition, and superior orbital fissure syndrome is also a reasonable diagnosis because it has that also presents as restriction of ocular motility and ptosis and total ophthalmoplegia. However, there are few points which are against superior orbital fissure syndrome, which we will be discussing in the differential diagnosis.
Very, very nice. I'm really impressed with this group, which is really active in asking the questions. Because only when you ask questions, I would encourage you not to worry about whether your question is relevant or irrelevant, because if you just put up these questions, then you will know why this is a diagnosis or why this is not a differential diagnosis. Okay, Mahesh, the next suggestion is, can this be mucormycosis?
Yes, sir. That is a very reasonable and a close differential diagnosis. Again, part of an infective condition. So mucormycosis is a excellent differential diagnosis to be considered in this case, considering all the other infective signs which we are seeing in this case. Yes, sir. Mucor can be a diagnosis.
This has come from Dr. Vandana. So congratulations, Vandana. Dr. Mahesh feels that you have talked about a very important topic. Of course, Mahesh will, after all this part is over, he will tell us why this is the diagnosis. But it's always nice for you people to give a commitment. We have... Okay, how about orbital apex syndrome or any other cavernous sinus disease? This is from Dr. Timothy.
Yes, orbital apex syndrome also is a good differential diagnosis because it falls in the spectrum of superior orbital fissure syndrome, orbital apex syndrome, and the cavernous sinus syndrome. So orbital apex syndrome is usually a superior orbital fissure syndrome plus an optic nerve involvement. So here there is a possible optic nerve involvement considering that the pupils were sluggish to light and the visual acuity has been reduced to 6/9. So optic nerve also is possibly involved, and orbital apex syndrome is a reasonable good diagnosis to be considered in this condition. In general, orbital apex syndrome is a non-infective inflammatory condition. So for the reasons discussed earlier, so this will vary slightly away from the orbital non-infective condition, but still it can be considered as an infective condition near the orbital apex. And so is the differential diagnosis for cavernous sinus lesion. Any cavernous sinus lesion can produce a similar condition, for example, a non-infective condition or a tumor. But we should remember that tumors in the cavernous sinus, like a meningioma, all these are actually slow-growing lesions, and they do not present acutely like this. They may present slowly with a proptosis, and they may present in a non-toxic fashion rather than a acute congestive fashion as in this case.
So the point which is coming out very, very clearly is not only do we concentrate only on the ptosis and the restriction of the movements part, we also consider whether it looks inflammatory or it looks infectious, whether it's acute or chronic, and more importantly, which one came first, or if the ptosis and the restriction came simultaneously. Everything has got a meaning. One of the Dr. Jagruti has asked whether it can be a Tolosa-Hunt syndrome. Mahesh.
That's a good question, sir. It can very well be a Tolosa-Hunt syndrome. Tolosa-Hunt syndrome is a constellation of findings seen in the orbital apex syndrome, superior orbital fissure syndrome, and cavernous sinus syndrome. And it is a diagnosis of exclusion. Provided we have excluded all the other conditions like an infective etiology and tumors, it can be called as Tolosa-Hunt syndrome, which is actually an idiopathic inflammatory condition in the orbital apex syndrome as well as cavernous sinus syndrome. So Tolosa-Hunt syndrome is an excellent differential diagnosis to be considered in this case.
One of the panelists, one of the participants has made a comment. It's not a question, but he says he would also assess for other cranial nerve deficits, that is specifically cranial nerve 5 and 7, to see if any pattern suspicious for cavernous sinus versus a brainstem disease. Mahesh, do you want to comment on this? Not just on the motor part, but he wants to specifically see for cranial nerve 5 and 7. And the reason why he wants to see is whether to differentiate between a cavernous sinus versus brainstem disease. Your comments, Mahesh?
That's an excellent point to be taken, sir. So fifth nerve is a very important nerve, and any cavernous sinus lesion, fifth nerve sensation will be impaired. Potentially, it can be impaired. So fifth nerve is very important in order to diagnose a cavernous sinus lesion, especially tumors. Also, seventh nerve can really be indicative of brainstem lesions. So that is also a valid point to be taken in this condition. And fifth nerve is a very important nerve.
Once again, for want of time, I would now request Mahesh to proceed with this. So just keep all these things in your mind, and as Mahesh progresses to the next stage. So these are all the things which should be in your mind, and now we will wait as to the next steps which Mahesh took while treating this patient. Mahesh, you can go ahead with the presentation.
So the next logical thing will be to check the random blood sugar in this patient, and as expected, it was a very high blood sugar. Remember that she was not a known diabetic, but for the first time she has presented to us with a high blood sugar and presented to the ophthalmologist with a total ophthalmoplegia. So based on these findings and the clinical findings, so we generate a differential diagnosis. which we have already discussed with excellent inputs from the participants, and we'll just be refreshing those differential diagnosis, whatever we have discussed so far. So as discussed, an infective cavernous sinus thrombosis will be on the list of one of the topmost differential diagnosis clinically. I would like to emphasize clinically because we have still not gone into the neuroimaging. So even at this stage itself, we can fairly good amount of clinical diagnosis we can make, and cavernous sinus thrombosis can be made in the first differential diagnosis. Why clinical diagnosis is important before sending to the imaging radiology? Because we need to give the radiologist a reasonable amount of differential diagnosis for him or her to look specifically at certain anatomical structures. Because imaging is a wide field and we need to give them clues to where to look for, otherwise it is easy to miss. So not everything can be diagnosed with the radiology alone. Clinically, we first diagnose and then refer appropriately for the imaging. So first differential clinical diagnosis will be a cavernous sinus thrombosis. The next one can be a non-infective, non-inflammatory condition like a carotica cavernous fistula, which we will be seeing subsequently why it is for and why against. The next differential diagnosis, as discussed, could be a superior orbital fissure syndrome and by extension orbital apex syndrome, which are all inflammatory conditions. And orbital cellulitis, as discussed, would also present like this as an infective condition because of the presentation mode. And also periorbital infections with extension into the orbit can also present in this condition. So the point here is it is an acute condition and an emergent investigation and emergent diagnosis is mandatory to help the patient. So now the next logical step for us to go into the neuroimaging part. So the first thing is, this is the patient scan, a CT scan showing certain clinical important findings. So I would request the participants to list out the positive findings. What scan is this? Number one, what are the positive findings seen in this scan? Please type it in the chat box and we'll give about 1 minute for participants to enter their findings. There's a lot of clues in this. Arrow marks are there. So it's easy. You can easily tell. You just need to look at the arrow marks and see what are the arrows which are being pointed upon. What scan is this and what view is this is important.
Mahesh, the answer is CT scan coronal view.
Yes, sir, that's right. They have got it right. First is a CT scan coronal view. The top one is a CT scan.
Sorry, Mahesh. I just want to acknowledge Dr. Lakshmi Prada. She has said it's a CT scan coronal view. And then Dr. Yatin Patil says it's an NCCT scan. So you have to tell us which type of scan is this, Mahesh?
No. So NCCT is a non-contrast CT scan. And here it is a CECT, contrast enhanced CT scan. This is a contrast enhanced CT scan, which is seen in this picture. And why we are saying it's a contrast? Because of the enhancing muscles and the enhancing superior ophthalmic vein.
Very, very nice. Mahesh, many of the doctors, at least 5 of them, have typed in enlarged superior ophthalmic vein and enlarged extraocular muscles.
Yes, sir. They have got it correct. So what we see here is a enlarged superior ophthalmic vein. And whenever we are in doubt, we always compare it with the normal side. Other side we have always, as we have twice here, you can see the normal superior ophthalmic vein here. And this is the enlarged superior ophthalmic vein as seen in the coronal section. Next is the axial section, which is seen here. Again, the enlarged superior ophthalmic vein, which is seen here as compared to the normal superior ophthalmic vein.
Mahesh, 2 doctors, Dr. Sonali and Dr. Henna, have said that they see thickened medial rectus.
Yes, sir, they are right. Fairly all the muscles are, extraocular muscles are thickened and enlarged. This is again as compared with the normal side, you can see here. We can also see the engorged extraocular muscles, which the reasons of which we will be seeing subsequently. They are right, sir. It's engorged extraocular muscles More so medial rectus, we can say, but as well as the other muscles, superior rectus and the inferior rectus.
So the CT scan, this is the coronal view, the top one, and it's a dilated superior ophthalmic vein with all muscles enlarged, with medial rectus more enlarged. Is that thing? And then Dr. Sagar has said, it's as rightly pointed by you, he also says, apart from medial rectus, the inferior rectus is also thickened.
Yes.
Then another doctor, again, Dr. Timothy, has said there is a dilated superior ophthalmic vein, muscle thickening of superior rectus, medial rectus, inferior rectus, and also a sinus disease with some indistinct medial orbital wall, possible orbital fat, stranding, and congested orbit.
Yes, sir. Some amount of sinus infection also is present in this case, considering that the patient would have had undetected diabetes for quite some time, and finally some infective focus has set in.
Well, I really want to congratulate this participant group. This group is really interactive, Mahesh.
Yes, sir.
And this is nice. Okay, why don't you proceed with the findings?
Yes. So that is an excellent piece of answers given by all the participants. You have hit the nail correctly. And now we'll just go to the normal scan, the normal CECT, is contrast enhanced coronal CT. And this CT, and as well as the patient CT, is at the level of the posterior orbit. As you might expect, we see the CT scan coronal view at the level of anterior, mid, and posterior orbit. And it is in the posterior orbit where we will be able to see the superior ophthalmic vein. So this is a normal patient CT for comparison. And you can see how small the superior ophthalmic vein is there in the posterior orbit. And you can compare it with the enlarged superior ophthalmic vein in the patient. Again, we are seeing this is an axial CT scan at the level of this is at the level of the posterior orbit, and this is at the level of the superior orbit, at the level of the superior rectus. This axial view is at the level of the superior rectus. So an axial view is something from the anterior to the posterior part of the skull. That is what an axial view is. And this is at the level of the superior rectus, the superior part of the orbit. You can see the superior ophthalmic vein coursing from the lateral aspect to the medial aspect. You can see here this side as well as this side. And you can see here the correspondingly our patient's superior ophthalmic vein is really enlarged as seen in this scan picture. Now another thought which I would like to tell the participants is, normally we always consider MRI as the preferential investigative mode of choice. So why did we consider CT scan? So all the postgraduates should remember that a CT scan is done in any acute emergency condition. An MRI always takes more time to be processed. It takes more time to do it, more time to be processed, and more time for the results anywhere. So in any acute condition, a CT scan is always preferred. Not only that, in any trauma condition, we want to look at the bones. A bone is best seen in the CT scan. An MRI is very bad or very poor in detecting calcium. So CT scan good in detecting calcium. So for fractures, CT scan, and for soft tissue lesions in a non-acute setting, you consider MRI. And thirdly, whenever you suspect a foreign body in the eye or elsewhere in a trauma, avoid an MRI scan for obvious reasons, where the foreign body may be dislodged within the eye, causing potential damage to the vital structures within the eye. So these are the points which you have to consider in ordering a CT scan. To recap, any acute condition in an emergency condition, for example, a severe headache, a patient comes to you, you suspect a subarachnoid hemorrhage, do a CT scan, don't wait for an MRI. Or in any condition of trauma where you want to look for fractures, and in any suspected intraorbital or intracranial foreign body, you consider CT scan, not an MRI in the acute setting. So now the story doesn't end there. Now further going, some more, we have only seen the orbital views now. Now this is the patient scan again at the level of the cavernous sinus. You can see the cavernous sinus. So I would like to request participants to think about what are the positive findings in this, which is arrow marked. Just think about the positive findings and type in your answers. We'll give 1 minute. Please type your answers. What do you see here? It is a coronal section at the level of the cavernous sinus, contrast enhanced.
Rakesh, as we wait for the answers, one of the participants has also said MRI is contraindicated in claustrophobic patients.
Yes, so that's an excellent point, valuable point, and I will take that point. Claustrophobia is a real contraindication. Maybe 1 in 100 patients that are really claustrophobic, and we just have to avoid it, sir. Thanks to that participant for bringing out this point.
Okay. So Dr. Vishalini has said the diagnosis, she says it's thrombosis of cavernous sinus.
Yes, sir. Diagnosis is correct, sir. The important finding which gives the diagnosis is what is seen in the CT scan. It's a crucial finding which gives us the diagnosis.
So the other participants have said there's hyperintensity in cavernous sinus. This is Dr. Anusha. And Dr. Anshuman has said there's an enlarged sinus.
Yes,
Do you
sir.
agree or disagree?
I agree with them, sir. There is an hyperintensity and there is some amount of enlargement and engorgement of the cavernous sinus. Still, one vital piece of finding has to be told, sir.
One doctor has now given a query filling defect.
Excellent, sir. That is the answer. There is a filling defect in the cavernous sinus, which is highly suggestive of thrombosis, which clinches the diagnosis of cavernous sinus thrombosis.
Mahesh, can you just explain to us as to, because you also said that was the one which you were looking for. Can you actually tell all the participants as how a filling defect was diagnosed using this picture?
Yes, sir. So in order to identify the filling defect, we need to know what a normal CT scan with contrast will look like at the level of the cavernous sinus. So now I am putting that picture of a normal CT scan contrast enhanced, and here you can really see the hyper density. In CT scan we call it density. Intensity is called in MRI, echogenicity in ultrasound. So we should call it density here in CT scan. So hyperdensity we see here, uniform hyperdensity at the level of the cavernous sinus, as evidenced by the IV contrast study. So contrasted with this finding, you can see the uniform filling in the opposite side, which is the normal side, and within this uniform filling, you can see the dark shadow, which is the hypoattenuation, which is the hypodensity here, which you see here, which is suggestive of a filling defect, and from that we call it possible thrombosis.
Very, very nice, and also congratulations to the participants who have actually identified all the points in this CT. And also, as Mahesh pointed out, very practical points as to why you should order a CT first rather than an MRI in such kind of a condition. Okay, Mahesh, you can proceed.
Yes. So from these clinical findings and from the imaging findings, we have diagnosed it as a possible cavernous sinus thrombosis. So now we will see the differential diagnosis, what is for and what is against, which we have already discussed. The first and foremost is the cavernous sinus thrombosis, and the points in favor is it. We have seen already total ophthalmoplegia, a dilated superior ophthalmic area as seen in the CT, a filling defect seen in the cavernous sinus suggestive of a thrombus, and an immunocompromised state with high blood sugar levels, again suggestive of an infective etiology. So the other differential diagnosis which we should look for are possibly a carotic cavernous sinus fistula. Why should we suspect a carotic cavernous sinus fistula? In this case, what are the points in favor of it? A proptosis might suggest a CCF. An enlarged superior ophthalmic vein also might be in a differential diagnosis for a CCF. The reason being that any backflow blockage which blocks the drainage of the veins, which leads to enlargement of the superior ophthalmic vein, can cause an enlarged SOV, for example, a cavernous sinus thrombosis or a carotid cavernous fistula. CCF is a high flow, high pressure area which impairs the drainage of the venous system into the cavernous sinus because of the mixing of the high pressure system and the low pressure system. The high pressure system is a carotid system and the low pressure system is a venous system. So when the high pressure internal carotid artery, the carotid artery mixes with the low pressure ophthalmic vein, the pressure in the veins also increase, which retards the backflow of the superior ophthalmic vein, causing the superior ophthalmic vein to dilate. So in that context, CCF can be a potential differential diagnosis in this situation, along with the engorged extraocular muscles as well as the mild degree of proptosis. But what are the points against carotid cavernous fistula? The toxic presentation of this, our patient, an acute toxic presentation. The patient was really toxic and she has chemoosed, she was sick looking, and all those things should tell us that it's not a simple vascular problem. It's possibly some infective pathology is going on. Again, there is no filling defect in the cavernous sinus in a carotid cavernous fistula. In fact, the carotid cavernous fistula will be a engorged cavernous sinus because of the backflow resistance and the high pressure system within the cavernous sinus. The third differential diagnosis, superior orbital fissure syndrome, which we have seen already. The points for will be a total ophthalmoplegia with vision loss, and the points against will be less of proptosis and there will be no edema and no toxic features, and there will also be an enhancing orbital apex and cavernous sinus in superior orbital fissure syndrome and cavernous sinus syndrome. However, there will be no filling defect in the cavernous sinus syndrome, the superior orbital fissure syndrome, and the orbital apex syndromes. So because it's a non-infective but a pure inflammatory condition. So the other two infective conditions also have similar differential diagnosis. So with that, we have come to the diagnosis of a cavernous sinus thrombosis, which is usually a late complication of the infection of the central face in the danger triangle or the paranasal sinus. Now, what is a danger triangle? You can see here, this triangle, this line which joins the angles of the mouth to the root of the nose, here is called the danger triangle. Why is it danger? Because all these veins have got no valves. So they drain directly into the cavernous sinus. So as ophthalmologists, we have a direct bearing to know about this danger triangle, because once they develop a cavernous sinus infection, they may present to us with as like this, then ophthalmoplegia. They may present to us with an orbital cellulitis. So it's pertinent for us to know about this danger triangle, which causes a infection. So even a pinprick here, even a pricking of an acne here can potentially cause a cavernous sinus thrombosis for the reasons said above. So the commonest organisms are Staphylococcus or Streptococcus, Pneumococcus or gram-negative species, and as one participant pointed out, a fungal infection also is a potential cause. For example, a mucormycosis, which could have spread from the sinuses, is also an important differential diagnosis. The risk factors for development of a cavernous sinus thrombosis will be diabetes, as in our case, chronic steroid use, cancer patients, and as well as who are on chemotherapy. So all these potentially reduce the immunocompetent state of the individual, and in these conditions, we should suspect in the appropriate setting a cavernous sinus thrombosis. So how do we treat this case? First and foremost, we should not be treating this case. The moment cavernous sinus thrombosis, identify this as an emergency and a life-threatening condition. So the role of the ophthalmologist is to refer it immediately to the internist in an ICU care setup, work with the internal physician and admit them under the care of an internal physician to control the diabetes, give them high-dose antibiotics and systemic antifungals, all third-generation cephalosporins, metronidazole for gram-negative species, vancomycin, and antifungals have to be given under the supervision of an internist. And as ophthalmologists, we can go and monitor these patients to assess the progress of these patients. But as ophthalmologists, it's better we don't take the primary responsibility of treating these patients, but refer appropriately, emergently. So that is about cavernous sinus thrombosis. So we have
Mahesh,
got, yes, sir.
One question or a comment from Dr. Goran. Comment is we put for and against, right? And he says non-pulsatile proptosis is against CCF.
Yes, sir. That's a valuable point, especially in a case of a direct CCF. Whenever there is a high pressure CCF, a non-pulsatile proptosis. Yes, that's a point against. It's a valid.
Again, congratulations, Goran. This is what we want this panel to be. We learn from you as well. And this also means that you are able to think laterally and then give this kind of a thing. Keep this enthusiasm going. This actually will stimulate the speaker also to remain focused. Once again, congratulations. Mahesh, you can proceed with the second case.
Yes, sir. Thanks to that participant for bringing that point. So now we'll go to the case number 2. So now this is a young female, a 35-year-old female, who presented to the ophthalmologist with a drooping of the right upper lid of 1 month duration. Otherwise, she is asymptomatic. Her visual acuity is normal, 6/6 both the eyes. Now I'm showing the clinical photograph of this patient. This is a spotter. What are the clinical findings and what is the diagnosis? What are all the clinical findings and what is the diagnosis? It's a spotter. Please type out.
Dr. Manogna Mandava is the full name, and he says the patient is a Horner's syndrome.
That's a very valuable diagnosis. So what are the points in favor?
Dr. Manogna has also said because there is ptosis and meiosis.
Yes, sir. That's an appropriate, correct answer. So it is readily apparent that this patient has got meiosis and ptosis here. It's a very obvious ptosis here and some amount of inverse ptosis also here because of the paralysis of the smooth muscles here also, the lower leg also.
Mahesh, there is another interesting observation. Dr. Ananthalakshmi, she said ptosis, but also she said left eye pupil is mid-dilated.
In this, yes, sir. In this setting, because of the relatively dimly lit room, the normal pupils have little dilated, and we can see the smaller pupil here. So we can take it as a normal pupil, sir. Left eye. It appears to be mid-dilated in a relatively darkened room with the photographic light.
Yeah, it looks like this thing, and so Ananthalakshmi is not wrong for making that comment, which is very good. Again, another Dr. Kannan says, why not ocular myasthenia?
Okay. So that's a good question, sir. Ocular myasthenia can also present with ptosis, but there are certain points in ocular myasthenia which rules out myasthenia. Myasthenia does not involve the pupils in any way. So pupils is a smooth muscle and myasthenia involves the skeletal muscles. So whenever there is a pupil involvement, we literally rule out myasthenia. And because of the prominent pupil finding, we can fairly rule out myasthenia.
Again, another comment by Dr. Vignesh, who says left eye ptosis and anisocoria Horner's. And Ninu Alex says ptosis, meiosis, inophthalmos. Shreya says ptosis, anisocoria. So everybody has got the ptosis and meiosis. Vandana wants to say that there is no meiosis. In fact, she wants to side with the other person who says the other eye pupil is dilated. Mahesh, Vandana says no meiosis. Vandana was the person, I think, who said mucormycosis.
Yes. So we are that's a valuable counterpoint and alternative way of thinking, sir. So now whenever we are confronted with Dr. Vandana is not wrong in considering the left eye to be the affected eye and the right eye to be the normal eye. So whenever we are confronted with an anisocoria, then we have to look at whether the larger pupil is the affected pupil or the smaller pupil is the affected pupil. So in order to differentiate this, we look at the pupillary constriction of the larger pupil. So if the larger pupil constricts well to light and accommodation, then it is considered to be the normal pupil. Then we consider the other pupil, the smaller pupil, to be abnormal. So in this patient, the left eye constricted well to light, which is not seen in this photograph, but it constricted well to light and it constricted well to accommodation. So we can fairly consider the left eye to be the normal pupil, and the right eye also constricted to some degree to light, but it failed to dilate in a dark situation. It failed to dilate well in a darker room, so which is suggestive of a sympathetic palsy. So that is another way of looking at anisocoria. What Dr. Vandana has said is another way of looking, and from that we deduce which is the affected pupil by looking at the light reaction of the larger pupil or the dilatation or any dilatation lag in the smaller pupil.
Mahesh, in response to the comment made by Dr. Kannan that it may be myasthenia, one other participant, Dr. Vignesh, says that ocular myasthenia is usually bilateral. What have you to say? Which one of them is right? It is usually bilateral, but of course it can present unilaterally as well, right?
Yes. So yes, sir. Myasthenia is, as said by Dr. Kannan, is very much right. Is 99%. It is bilateral, but always or most of the time it starts with one eye and eventually involves the other eye. But many times it can present bilaterally also to the ophthalmologist. But one of the key clues in myasthenia is it is usually an asymmetric condition. One eye is more ptotic than the other. So it is not wrong to consider myasthenia. Forgetting the pupil, it is not wrong to consider myasthenia as a differential diagnosis in this condition. It can eventually become bilateral, but it can start unilaterally.
Mahesh, Dr. Kishore Kumar is asking, is there a component of telecanthus in here, in this case?
I don't think so, sir. It is normal. It's normal, sir. Normal.
Okay. So just to add to the differentials, one of the participant, Aditya, is saying would also like to rule out right lower motor neuron 7th nerve involvement because left eye brow seems slightly raised as compared to the right. Just to add to the differentials.
It can be considered, sir. Yes, sir. It can be considered, but the lag ophthalmos have to be demonstrated to confirm the lower motor neuron 7th nerve.
I think one of the important points coming out in all this discussion is to be cognizant of the fact, the ptosis is apparent, but always be very, very clear. Not in this patient. In general, I'm saying if there is a ptosis, be aware that whether it's a ptosis of the right eye or a proptosis of the left eye. I'm not talking about this case. In general, I think that was also one of the merits in the discussion. When one pupil is constricted, that person might say, no, that's a normal pupil, but the other eye pupil is semi-dilated. So I think that's a very, very important discussion points which are coming up in this. There is another thing which says anisocoria in the dark is suggestive of Horner's syndrome. Dr. Vishalini and Dr. Shreya, who seem to be suggesting that anisocoria in the dark is more suggestive of Horner's syndrome. Your comments, Mahesh?
Yes, sir. So anisocoria, which is aggravated in the dark, which becomes more prominent in the dark, is suggestive of Horner's syndrome, because in Horner's syndrome, the involved pupil fails to dilate, whereas the normal pupil dilates very well. Similarly, contrarily, the anisocoria more in bright light, where the good pupil constricts very well and the involved pupil fails to constrict as much. It is aggravated more in bright light than the larger pupil is the involved eye. So they are correct, sir. Anisocoria is more prominent in dark in Horner's syndrome.
And Dr. Suganya says it cannot be myasthenia because the pupil in myasthenia is normal usually. Since there is an associated pupillary problem, this is something else other than myasthenia.
Yes, sir. That is right. The moment the pupil is involved, there are few catch points to rule out myasthenia, like whenever the pupil is involved, it is not myasthenia. whenever the sensory symptoms are present, like for example, a corneal sensation is absent, or whenever there are other sensory signs are absent, because myasthenia is more of a motor neuromuscular junction. So if we have a corneal sensation deficit or other sensory deficits, then it is not myasthenia. Whenever there is a severe headache, then it is not myasthenia. We need to rule out other intracranial lesions and we need to do a neuroimaging. So these are the points which click that it may not be myasthenia, it may be something else. So because the pupils are possibly involved in some way here, we can fairly rule out myasthenia, sir.
Very nice. And as I said, I continue to be impressed with the group today. Very, very active group, typing in chats. In fact, I'm not reading out many of things because some of it is already covered by the other participants. And with want of time, I would now request Mahesh to proceed with the presentation.
So I can congratulate all the participants for making a quick diagnosis of this patient and telling out the correct important clinical findings, and I also congratulate the certain speakers for pointing out that the other eye may be involved. So this stresses the importance of observation, that it may be the other eye also may be involved in some way or the other, making an alternate differential diagnosis. So it was a Horner's syndrome. Now we come to additional clinical findings. Now may I ask any participants to type in their answers. What is this clinical finding and how does it give a bearing on our Horner's syndrome? How do we connect the two?
Dr. J. Oswald says Pancoast.
Pancoast tumor is an important differential diagnosis in Horner's syndrome, but that it may not directly relate to this clinical finding seen in the hands.
And
but it's a good thought.
Yeah, and the other persons are saying Dupuytren's contracture. Rohan Arora says Dupuytren's contracture.
Yes. Dupuytren's contracture, if I remember my orthopedics right, it is due to, I think, a contracture within the canal, the facial canal in the wrist. And it's maybe not a neurogenic problem. It's more due to a mechanical tendonitis. That's what I think I remember. So it may not be, it is a good differential, but it does not have a direct correlation with our case of Horner's syndrome. But it's a good attempt and a good differential.
Dr. Kundavai brings out a very interesting and important point. She says there is hypertrophy of small muscles of the hand.
That is right, sir. She is right, sir. There is a hypertrophy of the thenar and the hypothenar muscles and wasting of the hand muscles. Yes, she is right, sir.
Dr. Nandini is saying Erb's palsy.
Yes, there. She's close to the answer. Yes.
Erb's palsy.
How does it correlate with our diagnosis?
Okay.
How do we connect the two?
And the Erb's palsy. Let me read out other things. Dr. Vishalini says probably right cervical plexus involvement.
She has almost got the answer. It is due to the cervical plexus involvement, the brachial plexus. We will see how it goes.
Okay, many of them have mentioned about the wasting of the thenar muscles. Dr. Henna has said median nerve palsy, cervical rib.
Yes, sir. All are close answers to the diagnosis. They are nearly.
Mahesh, I'm sure you are also seeing the responses. There are 34 responses. 34. I'm really impressed by this group. But I think we should. There is somebody who says clumky palsy, and then there are two people who say clumky palsy. Neenu Alexander and Prabhu Pandyan. What is this clumky palsy business? Are you aware, Mahesh?
Yes, sir. So I can see, yes. All these are related to the nerve roots and they are all close to the answer. So in order for me to acknowledge them, I need to give the real answer.
I think you should go ahead, but I'm really, the numbers, I mean, we cannot answer every one of them. It's now going on to 41. I think you should just proceed with your slides. But very impressive feedback from our participants today.
They cannot get closer to the answer than this.
Yes.
I'll proceed, sir. I'll proceed.
Yes.
So now, the next logical step in the evaluation of a harness is to do a neuro-imaging. Practically, a lot of pharmacological tests are described, which are good to understand the level of lesions. But practically, we may not get all the pharmacological agents in our country. So we really need to do a good neuroimaging covering the entire sympathetic pathway. So we'll see what happens now. Now, this is the MRI scan. I told that all soft tissue lesions you consider MRI. Now, this is an MRI scan, T1 weighted image of the patient. So, what are the findings here? Some markings are there which give the clue, but what are the findings? Please type out your answers in the chat box, which explain both the signs seen in our patient.
Mahesh, I'm sorry, I was not reading, but I was on mean. Some of the answers are like hummingbird sign, progressive supranuclear palsy, cerebellar tonsil herniation, split of spinal cord, brainstem pushed down, Arnold-Chiari syndrome, compression under the pons region, tonsillar herniation CVJ with syringomyelia, split of the spinal cord. So these are all the things. A paraganglioma by Dr. Nandini Sriram, and then Sujay Jaju says syringomyelia. These are all the differential diagnoses put by our group, Mahesh.
Yes, sir. So many of them are correct, and many of them are close to the answers. So in order to explain these findings, now I will explain what a normal scan looks like in the normal patient. So now, in order to understand these images, we need to know what a normal image is. It's a T1 weighted MRI scan of the brain. So now, why do we say T1? Because all the fluid here, the CSF fluid is dark, hypo-intense. And then the important structures pertaining to this case will be, you can see here, some of them have got the answers right. This is the tonsils of the cerebellum. And this is a line which connects the anterior part of the spinal opening, foramen magnum, which is called the basion, and the posterior part of the opening, which is called the opistheon. This is called as Mac-Ray line, which connects the anterior part and the posterior part. Basion, posteriorly opistheon. So normally the cerebellar tonsils lie 1 millimeter above this line. Further, we can see the spinal cord here, which is normal, which is a normal spinal cord. So now compare this with this Mac-Ray line here. You can see the tonsils of the cerebellum has descended. How much it has descended? It has descended number 2 is 1.56 centimeter. It has descended down below this Mac-Ray line. So anything above 5 millimeter can potentially cause some clinical findings. Not every tonsillar herniation need to produce findings, but there are certain instances where it may produce some findings. So what does this tonsillar herniation does? It blocks the CSF pathway. When it blocks the CSF and obstructs the CSF pathway, some amount of CSF is sequestered within the spinal cord. So you can see here, the tonsils have gone down. You can see here, there is a CSF filled space within this spinal cord. So this has led to syringomyelia caused by the descent of cerebellar tonsils. So now how do we connect our findings? So this syringomyelia has disrupted our sympathetic pathway, which runs along the lateral column of the spinal cord. And this has also disrupted the C2 to C4 spinal canal and the spinal outflow, the nervous outflow, which has led to the wasting of the hand muscles. So this way we are connecting both, and we are able to say that it is a central harness or a first order neuron harness, which has led to syringomyelia and wasting of the muscles. So this herniation of the tonsils can be congenital or acquired. Congenital, what is called as Arnold-Chiari malformation. There are also acquired conditions, and this is a craniovertebral junction anomaly. So for the ophthalmologist, we have to remember that some of these CV junction anomalies can lead to a downbeat nystagmus. So if you see a downbeat, the pars component downbeat nystagmus, think of a craniovertebral CV junction anomaly, and in this case, it has led to a Horner syndrome. This patient did not have a downbeat nystagmus, but in some cases, it can have a downbeat nystagmus in these situations. So now that is how this wasting of the muscles were related to our Horner syndrome because of syringomyelia and involvement of the C2 to C4 plexus, cervical plexus. So we'll quickly recap the sympathetic pathway outflow. Starts from the hypothalamus, runs down the intermediate lateral gray column of the spinal canal till C8 to T2, which is the cerebrospinal center of budge. And our involvement, syringomyelia, was somewhere around this region, C2 to C4, which caused the disruption as well as the cervical outflow plexus. And from here to here, the hypothalamus to here, the cerebrospinal center, it is the first order neuron. And from here, the second order neuron goes and travels along the through the apex of the lung and travels along the subclavian artery, reaching the superior cervical ganglion. Until here, it is a second order neuron. So this first order neuron and the second order neuron constitutes the preganglionic sympathetic pathway. And from the postganglionic region, travels along again the internal carotid artery and then along the nasociliary vessels and the ciliary arteries, and it goes to supply the sympathetic Muller's muscle as well as the dilator pupillae. So that is the anatomy of the sympathetic pathway. Because of its long course, we need to image the brain as well as the lungs as well as the entire pathway of the sympathetic plexus. So summarizing, we have meiosis, ptosis, anhydrosis, anisocoria worse in the dark, and a dilatation lag. Dilatation lag because the sympathetically affected eye fails to catch up with the normal eye. Remember, this dilatation lag is important only in the first 5 seconds. If you see after 10 seconds, this eye will catch up. So we need to look at it in the first 5 seconds for it to really appreciate a dilatation lag. The differential diagnosis will be preganglionic Wallenberg syndrome, pica infarct, posterior inferior cerebellar artery infarct. Remember that Wallenberg syndrome, remember the general medicine. Finally, we all studied lateral medullary syndrome. And we also know that sympathetic plexus pass along the lateral medulla. And Wallenberg pica infarct is very common actually. That can cause preganglionic Horner syndrome, syringomyelia, which we have seen just for, Pankos tumor, lung apex tumor, aortic aneurysm. These are all second order neurons. Pankos tumor and aortic aneurysm. Postganglionic could be cluster headache, idiopathic, cavernous sinus inflammation, or herpes zoster ophthalmicus. Either preganglionic or postganglionic internal carotid artery dissection. Remember, ICA dissection is a medical emergency. And any patient coming acutely to you with Horner syndrome, think of ICA dissection because it is potentially life-threatening. So summarizing anisocoria, imagine right eye is involved in all situations. A mydriatic installation, right eye. Normal lighting, it is dilated. AD's pupil, dilated. And a mydriatic distillation, all situations it remains dilated. AD's pupil, it remains dilated. Turner palsy, it remains dilated. Horner syndrome, it remains constricted. Next is a dim illumination. A mydriatic will remain dilated. AD's pupil will remain dilated. But Turner palsy also will remain dilated. Whereas Horner syndrome will remain constricted. Whereas a normal pupil will dilate here. In bright illumination, you can see it remains dilated. Whereas a Horner syndrome will constrict. AD's pupil will not constrict because it responds poorly to light. Turner palsy will not constrict. The Turner pupil involved Turner palsy. And accommodation, AD's pupil will constrict. Remember that accommodation reflex is better in AD's pupil, slow tonic accommodation. Third nerve palsy will remain dilated, whereas Horner syndrome will constrict to accommodation. Finally, a 2% pilocarpine, the mydriatic will not constrict readily to pilocarpine. AD's people will constrict to weak pilocarpine also. A third nerve palsy will constrict to pilocarpine because we are supplying acetylcholine externally in the form of pilocarpine. It constricts because there is lack of neurotransmitter in the third nerve palsy. And Horner syndrome will constrict. These are the other clinical features. You can have in AD's people vermiform contraction, absent tendon reflexes, ptosis, eyes deviate laterally and there will be pain. You will have a limitation of the extraocular movements. And Horner syndrome, remember, there will be a partial ptosis. So that's about case 2, Horner syndrome.
Mahesh, yes, there are some questions. One of the doctors had said, can this be a CP angle tumor? I mean, before we knew the diagnosis, just by the finding.
Yes.
What are the points favor? What are the points against?
CP angle tumors will have, it may present with seventh nerve, lower motor neuron seventh nerve palsy. It can have diminished corneal sensation. CP angle tumors can have decreased corneal sensation. And many instances, it's a posterior fossa tumor. So posterior fossa lesions cause papilledema early because of the small space in the posterior fossa. So they may potentially present to us with papilledema. And CP angle tumors also can cause what are called Brent's nystagmus. Brent's nystagmus are high amplitude, high frequency nystagmus on the side of the lesion and low amplitude, low frequency nystagmus on the opposite side of the lesion, beating to the opposite side on the other side. And of course, hearing will be impaired and corneal sensation will be reduced. So it can be a distant differential diagnosis considering there is some amount of ptosis, but there is no direct relation with CP angle tumor in this condition, sir.
Okay. Dr. Rohan Arora is asking us, can we expect sensory or motor deficits at lower spinal levels as well, considering a compressive lesion is present at the cervical spine? I mean, can we expect sensory or motor deficits at lower spinal levels as well?
Yes, sir. If there is a compressive lesion, the lower spinal level, it is possible to have total deficits, to have a total sensory as well as motor deficit. It is possible.
Okay, so Dr. Rohan Arora's question is very relevant. Dr. Mahesh agrees with that. Dr. Deepika says, loss of ciliospinal reflex, is it a reliable test for honors?
It can be a reliable test, sir, but we don't do it routinely. But for academic interest, it can be considered as a reliable test. But it's not, clinically, it's not as reliable. That's what I would say.
Arnold Chiari, you want to make a comment on this differential diagnosis of at least 3 people have mentioned Arnold Chiari syndrome.
Arnold Chiari malformation is usually a congenital condition where there is a tonsillar herniation, and in most instances it is asymptomatic. In many patients, less than 5 millimeters of tonsillar herniation, usually they remain asymptomatic. And majority of the instances, patients remain asymptomatic. So if it remains symptomatic, or if there are other neurological signs, then neurosurgeons may resort to reduction of these tonsils and closure of this defect and a reduction in the size of the foramen magnum. They may undertake a surgery, but in most instances, it remains asymptomatic. And in some instances, it may present with the, as we discussed, a downbeat nystagmus, because it's a craniovertebral junction anomaly. So many times it's incidentally seen in the neuroimaging, which we order for other conditions. But as ophthalmologists, we see this it's better we take the opinion of a neurosurgeon whether to intervene or not. So it's obligatory for us to refer this to a neurosurgeon. Whether they will intervene or not, they will decide. Yes, sir.
Mahesh, Dr. Richa Kaushik is asking how to elicit a seriospinal reflex.
So,
you pass if you don't want to. If it has to be done by a medical person, we can always tell Richa.
Actually, it is a painful stimulus. Any painful stimulus, it leads to a rapid ipsilateral dilatation of the pupil, but it's not routinely done. So any painful or startling stimulus can be given to the nape of the neck, which may elicit this reflex. Frankly, I have not elicited this reflex in day-to-day practice, so I'm not sure how well it can be positive.
Yeah, but I think Richard is bringing out a very interesting point, because sometimes we just read, no, seriospinal reflex is present, and the question is how practical it is. And Mahesh says it's not very practical. And one of the participants has said pinching of the neck causes dilatation of the pupil.
Yes,
same thing like what Mahesh said. So that is how you elicit a seriospinal reflex. But Mahesh also said practically it is not a great test to begin. So anyway, Richa's question is answered with this. Mahesh, I think do you have a case which you can present in 10 minutes straight without asking any questions, or we can?
I can present a quick case, sir.
Yeah, you can present a quick case, but no
without
question.
asking questions.
Yeah, without asking a question, just for the interest of time, because we did not anticipate so much of discussion, which, by the way, was very, very good. I think that's the way it should be. But maybe for this case, you can just pass off without questions to finish on time. Yeah.
So the last case will be a young boy who presented with headache, neck stiffness, and vomiting of 1 month duration. He was seen elsewhere. A CT brain with contrast was done, which was normal. He was diagnosed as a case of a idiopathic intracranial hypertension or a pseudo-tumor cerebri without a humor, and he was started on tablet Diamox, as we would do for any case of pseudo-tumor cerebri. So in spite of 1 month of Diamox, he did not get relieved, and he came with a visual acuity of 6/6. Pupils were normal. The extraocular movements were normal. And this was his fundus finding. So it was obvious that he had a papilledema. It has got an angry looking disc. It has got a blurred margins. The vessels are obscured at the edge of the disc, suggesting that it is a true papilledema. You can see the filling of the cup, and you can see the engorged veins here because of the compression of the retinal veins. So now, the next logical step in any case of papilledema would be to check the blood pressure. So before going on to a scan or other neuroimaging modalities, check the blood pressure of 120/80. BP was normal in this patient, the left upper limb. And the next step would be to look at the slit lamp to rule out any uveitic pathology, which may also present to us as disc edema. So for perspective, VKH cases, Rada syndrome cases can present with bilateral disc edema, and they can also have headaches. And imaging will be normal. It can be erroneously diagnosed as pseudotumor cerebri. So as ophthalmologists, we always look into the slit lamp and do a good dilated examination to make sure that elsewhere the retina is normal with no serous detachments. So now, further, once we have diagnosed the papilledema, further we need to evaluate. So there are some red flags in the treatment of the patient, because a CT with contrast alone would not be enough in the evaluation of a case with papilledema. We always need a MRI with an MR venogram. So this is a normal MRI T1 sagittal CT which shows a normal brain structures, and we'll compare it with our patient. You can see here this is a plain study which is an enhancing at the superior sagittal sinus level. So any blood would normally be dark in the MRI because of the rapid flow of the blood, which is called as flow void. And whenever the blood stagnates, it can lead to this stagnation of the blood like this and show up even without a contrast. With contrast, of course, all the vessels would be enhancing. This is a normal MRV for comparison, and I can see totally occluded superior sagittal sinus. And again, normal MRA T1 axial. You can see here the transverse sinus is showing up without contrast because of the stagnant blood, as well as the sigmoid sinus. So anatomically, we are looking at the superior sagittal sinus, the transverse sinus, or the sigmoid sinus for any thrombosis which can present with papilledema. So they can present with headache, diplopia, seizures, or altered sensorium. And these patients, once diagnosed, have to be referred to the neurologist for appropriate treatment with apparenization. I'm done with the third case, sir.
Very, very nice, Mahesh. An important case in a young boy. So with this, we come to the end of today's presentation. So before we close, Mahesh, some question. One of the doctors is asking, do you want to consider TB basal meningitis for the last case?
Yes, TB, arachnoiditis and basal meningitis is an important differential diagnosis. The patient will be toxic there, and it will be readily apparent in the Neuro-imaging, a basal meningitis, where there will be enhancing exudates in the base of the skull, and that's an important differential diagnosis. But the key is the patient will be toxic, and the patient will have profound neck stiffness also. Even CVT patients can have neck stiffness, but the patient will be more toxic in TB meningitis.
Thank you, Mahesh, for a very, very interesting session today. As we were just discussing. Okay, so I was about to propose a vote of thanks, but one of the doctors just given a comment. So by just seeing one side fundus, can I give diagnosis as papilledema when we can't see the other eye fundus due to lens changes? Practical question.
So this question has got two questions within it, I would say. So I would rephrase it as, is unilateral papilledema possible? Yes, it is occasionally possible whenever the other eye is atrophic, or sometimes in idiopathic intraocular hypertension or any other condition, whenever there is an anomalous optic nerve sheath, there is failure of transmission of the raised intracranial pressure into one side optic nerve, and it can present with other side papilledema alone, when in fact there is a real true raised intracranial pressure. So going to the second part of the question, due to lens changes, whether we can diagnose papilledema. Well, ophthalmoscopically it may be difficult. There are two ways to look at it. One, we can look at the B scan to describe what is called as a crescent sign. Crescent sign is a fluid in the sclera which appears as a crescent and which is suggestive of a papilledema. It is a very subjective test. If somebody is very well versed in detecting that, then crescent sign is very useful in a B scan. And the second thing is, if we have doubt, we can always do a neuro-imaging, and radiologists have got specific findings to say that it's possible papilledema, like dilated perioptic nerve sheath in the retroorbital region, and also sometimes reverse cupping, what they say, reverse cupping, where there will be jutting forward into the vitreous of the optic nerve head, which will be seen in the MRI. So these two things can suggest that the other eye also has got possible disc edema. Of course, ophthalmoscopically, we may not be able to diagnose it.
Very interesting question.
Yes.
Sir, can you please tell how to evaluate pupil reactions in a one-eyed patient?
Okay. It depends on whether the other eye is totally, if it is, for example, if there is no light perception, then we can just look at the direct reaction in this eye. and I'm not able to tell whether in one eye, it depends on if the other eye has got a no light perception, and if the other eye's pupil is reacting and the other structures are normal in the other eye, then we can shine the light in the other eye and look for the consensual reaction in the normal eye. And we can also look at the consensual reaction in the affected eye if the other eye has got, even if it is no light perception, due to, for example, an optic atrophy. So we have to remember that even if it is a total afferent pupillary defect because of an optic nerve lesion, the pupil will be normal in size because of the consensual response. There is what is called as a double decussation, one at the level of the chiasm and one at the level of the pretectal nucleus, which ensures that there is a good consensual response in the affected eye also, and also ensures that the pupil remains equal in size to the normal eye. So these are the two ways we can look at the one-eyed patient.
Ladies and gentlemen, I'm forced to conclude this session. I'm really happy and encouraged by your enthusiasm. This also means probably we can hold the next Neuro-ophthalmic conference also in the next 2 months instead of the traditional waiting period of 4 months. So overall, I would like to thank Mahesh for a very nice presentation. But more importantly, I would like to thank each one of the participants. I have participated in many sessions, but this time it's really nice that so many of you enthusiastically participated, and we do hope that this sort of interaction would continue in our future DigiNerve sessions as well.